Hello dear students, today we are going to discuss the topic on morphological effects, outcome and termination of acute inflammation. The main objectives of the topic are to understand the morphological effects of acute inflammation, to know the possible outcomes of acute inflammation and to understand the possible ways of termination of acute inflammation. Now, let's first see what inflammation is. Inflammation is a part of complex biological response of body tissues to harmful stimuli such as pathogens, damaged cells or irritants, and is a protective response involving immune cells, blood vessels and molecular mediators. The function of inflammation is to eliminate the initial cause of cell injury, clear out necrotic cells and damaged tissues to initiate tissue repair. Inflammation can be classified as either acute or chronic. Acute inflammation is the initial response of the body to harmful stimuli and is achieved by the increased movement of plasma and leukocytes from the blood into the injured tissues. A series of biochemical events propagates and matures the inflammatory response involving the local vascular system, the immune system and various cells within the injured tissue. Prolonged inflammation, known as chronic inflammation, leads to a progressive shift in the type of cells present at the site of inflammation, such as mononuclear cells, and is characterized by simultaneous destruction and healing of the tissue from the inflammatory process. Now, morphological effects of acute inflammation. Inflammation of an organ is usually named by adding the suffix itis to its Latin name. For example, appendicitis, hepatitis, cholecystitis, and meningitis. A few morphological effects of acute inflammation are as pseudomembranous inflammation. It is inflammatory response of mucous surface, bowel, respiratory to toxins of diphtheria or irritant gases. As a result of denudation of epithelium, plasma exudes on the surface where it coagulates and together with necrosed epithelium forms false membrane that gives this type of inflammation its name. Second is serous inflammation. It's characterized by the outpouring of a watery, relatively protein-poor fluid that, depending on the site of injury, derives either from the plasma or from the secretions of mesothelial cells lining the peritoneal, pleural and pericardial cavities. The skin blister resulting from a burn or viral infection is a good example of the accumulation of a serous effusion either within or immediately beneath the epidermis of the skin. Fluid in a serous cavity is called an effusion. Third, fibrinous inflammation occurs as a consequence of more severe injuries resulting in greater vascular permeability that allows larger molecules to pass through the endothelial barrier. Histologically, the accumulated extravascular fibrin appears as an eosinophilic meshwork of threads or sometimes as an amorphous coagulum. A fibrinous exudate is characteristic of inflammation in the lining of body cavities such as the meninges, pericardium and pleura. Fourth is suppuration or abscess formation. When acute bacterial infection is accompanied by intense neutrophilic infiltrate in the inflamed tissue, it results in tissue necrosis. A cavity is formed which is called an abscess and contains purulent exudates or pus, and the process of abscess formation is known as suppuration. The bacteria which cause suppuration are called pyogenic. Microscopically, pus is a creamy or opaque in appearance and is composed of numerous dead as well as living neutrophils, some red cells, fragments of tissue debris and fibrin. In old pus macrophages and cholesterol crystals are also present. An abscess may be discharged to the surface due to increased pressure inside or may require drainage by the surgeon. Due to tissue destruction, resolution does not occur, but instead healing by fibrous scarring takes place. Some of the common examples of abscess formation are as under. First, boil or furuncle, which is an acute inflammation via hair follicles in the dermal tissues. Second is carbuncle, is seen in untreated diabetics and occurs as a loculated abscess in the dermis and soft tissues of the neck. Next is ulcer. An ulcer is a local defect or excavation of the surface of an organ or tissue that is produced by necrosis of cells and shedding of necrotic and inflammatory tissue. Ulceration can occur only when tissue necrosis and resultant inflammation exist on or near a surface. Ulcers are most commonly encountered in the mucus of the mouth, stomach, intestines, or genitourinary tract. Ulcerations are best exemplified by peptic ulcer of the stomach or duodenum, in which acute and chronic inflammation coexist. During the acute stage, there is intense polymorphonuclear infiltration and vascular dilation in the margins of the defect. With chronicity, the margins and base of the ulcer develop scarring with the accumulation of lymphocytes, macrophages, and plasma cells. Now, cellulitis. It's caused by Streptococcus pyogenes. The bacteria produce hyaluronidase, which digests dermal connective tissue, leading to diffuse spread of bacteria and formation of purulent exudate along the dermis. Cellulitis is rapidly spreading. Erythematous cutaneous swelling on the face or on the body or on an extremity in middle-aged persons. The rash has a sharp, well-demarcated border and systemic symptoms. Now, bacterial infection of the blood. This includes following three conditions. First, bacteremia is defined as a presence of small number of bacteria in the blood which do not multiply significantly. They are commonly not detected by direct microscopy. Blood culture is done for their detection. For example, infection with Salmonella typhi, Escherichia coli, and Streptococcus viridans. Next is septicemia. Septicemia means presence of rapidly multiplying, highly pathogenic bacteria in the blood, for example, pyogenic cocci. Septicemia is generally accompanied by systemic effects like toxemia, multiple small hemorrhages, and disseminated intravascular coagulation. Next is pyemia. Pyemia is the dissemination of small septic thrombi in the blood, which cause their effects at the site where they are lodged. This can result in pyemic abscesses or septic infarcts. Pyemia abscesses are multiple small abscesses in various organs such as in cerebral cortex, myocardium, lungs, and renal cortex, resulting from very small emboli fragmented from septic thrombus. Next is outcome and termination of acute inflammation. Once acute inflammation has begun, a number of outcomes may follow. These include healing and repair, fibrosis, suppression, and chronic inflammation. The outcome depends on the type of tissue involved and the amount of tissue destruction that has occurred, which are in turn related to the cause of injury. The termination of inflammation depends upon the degree of inflammation and the amount of damage done. This takes place only when the inflammation has been slight. The exudate is taken up by the lymphatics and returned to the circulation. Any degenerated cell will be taken up by the wandering leukocytes and the tissue will resume its normal condition. Next is healing and repair. During the healing process, damaged cells capable of proliferation regenerate. Different types of cells vary in their ability to regenerate. Some cells, such as epithelial cells, regenerate easily, whereas others, such as liver cells, do not normally proliferate but can be stimulated to do so after damage has occurred. Still, other types of cells are incapable of regeneration. For regeneration to be successful, it's also necessary that the structure of the tissue be simple enough to reconstruct. In some cases, the failure to replicate the original framework of an organ can lead to disease. This is the case in cirrhosis of the liver, in which regeneration of damaged tissue results in the construction of abnormal structures that can lead to hemorrhaging and death. Repair, which occurs when tissue damage is substantial or the normal tissue architecture cannot be regenerated successfully, results in the formation of a fibrous scar. Now, fibrosis. It's the formation of excess fibrous connective tissue in an organ or tissue in a reactive process. This can be reactive, benign, or pathological state. In response to injury, this is called scarring, and if fibrosis arises from a single cell line, this is called a fibroma. Physiologically, fibrosis acts to deposit connective tissue which can obliterate the architecture and function of the underlying organ or tissue. Fibrosis can be used to describe the pathological state of excess deposition of fibrous tissue as well as the process of connective tissue deposition in healing. Fibrosis is similar to the process of scarring in that both involve stimulated fibroblasts laying down connective tissue, including collagen and glycosaminoglycans. The process is initiated when immune cells such as macrophages release soluble factors that stimulate fibroblasts. The most well-characterized profibrotic mediator is transforming growth factor beta, which is released by macrophages as well as any damaged tissue between surfaces called interstitium. Now, it's necrosis. Necrosis is a form of cell injury which results in the premature death of cells in living tissues by autolysis. Necrosis is caused by factors external to the cell or tissue such as infection, toxins, or trauma, which result in the unregulated digestion of cell components. When cells die and undergo necrosis in vivo, the tissue site is rapidly infiltrated with leukocytes consisting initially of neutrophils followed by accumulation of monocytes. Cellular death due to necrosis does not follow the apoptotic signal transduction pathway, but rather various receptors are activated and result in the loss of cell membrane integrity and an uncontrolled release of products of cell death into the extracellular space. This initiates in the surrounding tissue an inflammatory response which prevents nearby phagocytes from locating and eliminating the dead cells by phagocytosis. For this reason, it's often necessary to remove necrotic tissue surgically, a procedure known as debridement. Untreated necrosis results in a build-up of decomposing dead tissue and cell debris at or near the site of the cell death. A classic example is gangrene. There are 6 distinctive morphological patterns of necrosis. First is coagulative necrosis. Coagulative necrosis is characterized by formation of gelatinous substance in dead tissues. Coagulative necrosis occurs primarily in tissues such as the kidney, heart, and adrenal glands. Second is liquefactive necrosis. In contrast to coagulative necrosis, is characterized by digestion of dead cells to form a viscous liquid mass. This is typical of bacterial or sometimes fungal infections because of their ability to stimulate an inflammatory response. The necrotic liquid mass is frequently creamy yellow due to the presence of dead leukocytes and is commonly known as pus. Third is gangrenous necrosis. Gangrenous necrosis can be considered a type of coagulative necrosis that resembles mummified tissue. Fourth is caseous necrosis. It can be considered a combination of coagulative and liquefactive necrosis, typically caused by mycobacteria, fungi, and some foreign substances. The necrotic tissue appears as white and friable, like clumped cheese. Dead cells disintegrate but are not completely digested, leaving granular particles. Granuloma has this characteristic. Next is fat necrosis. Fat necrosis is specialized necrosis of fat tissue, resulting from the action of activated lipases on fatty tissues such as the pancreas. In the pancreas, it leads to acute pancreatitis, a condition where the pancreatic enzymes leak out into the peritoneal cavity and liquefy the membrane by splitting the triglyceride esters into fatty acids through fat saponification. Next is fibrinoid necrosis. Fibrinoid necrosis is a special form of necrosis usually caused by immune-mediated vascular damage. It's marked by complexes of antigen and antibodies, sometimes referred to as immune complexes, deposited within arterial walls together with the fibrin. Now, suppuration. In suppuration, the inflammation has been destructive. There is actual loss of tissue with the formation of pus. Pus is a viscous liquid that consists mostly of dead and dying neutrophils and bacteria, cellular debris and fluid leaked from blood vessels. The most common cause of suppuration is infection with the pyogenic bacteria such as Staphylococcus and Streptococcus. Once pus begins to collect in a tissue, it becomes surrounded by a membrane, giving rise to a structure called an abscess. An abscess is virtually inaccessible to antibodies and is very difficult to treat. Sometimes a surgical incision is necessary to drain and eliminate it. Some abscesses, such as boils, can burst of their own accord. The abscess cavity then collapses and the tissue is replaced through the process of repair. In some cases, the pus may quickly escape to the surface of the body and be cast off. It may, however, have to burrow a long distance, as in a psoriasis abscess, before it can escape. Sometimes the pus may gain entrance into one of the cavities of the body, as the peritoneum or pleura, and give rise to inflammatory conditions there. Now, chronic inflammation. If the agent causing an inflammation cannot be eliminated, or if there is some interference with the healing process, an acute inflammatory response may progress to the chronic stage. Repeated episodes of acute inflammation also can give rise to chronic inflammation. The physical extent, duration, and effects of chronic inflammation vary with the cause of the injury and the body's ability to ameliorate the damage. In some cases, chronic inflammation is not a sequel to acute inflammation but an independent response. Some of the most common and disabling human diseases such as tuberculosis, rheumatoid arthritis, and chronic lung disease are characterized by this type of inflammation. Now, lymphadenitis. Localized acute inflammation and chronic inflammation may cause secondary inflammation of lymphatic channels and lymph nodes. The inflamed lymphatic channels in the skin appear as red streaks, and the lymph nodes are enlarged and painful. Microscopically, the lymph nodes show hyperplasia of lymphoid follicles and proliferation of mononuclear phagocytes in the signs. Now, termination of the acute inflammatory response. It is predictable that such a powerful system of host defense, with its inherent capacity to cause tissue damage, needs tight controls to minimize the damage. As inflammation develops, the process also triggers a variety of stop signals that serve to actively terminate the reaction. These active mechanisms include a switch in the production of pro-inflammatory leukotrienes to anti-inflammatory lipoxins form arachidonic acid. With this, we come to the conclusion of our lecture. Thanks for watching.